Hello and welcome to your online lecture for the course Altered Physiology 1. Today's lecture is titled Hematologic Disorders 2. It's the second of the hematological disorders lectures, and in this lecture we're mainly focusing on white blood cells. And you should recall that white blood cells are called leukocytes. So let's talk about some changes or alterations of leukocyte or white blood cell function. There are two types of disorders involving changes in leukocytes. The first one is either a quantitative disorder, and the next is a qualitative disorder. So quantitative, qualitative. One referring to quantity, of course, the other referring to quality. In the case of quantitative disorders, we have two different types. We have leukocytosis and leukopenia. Leukocytosis is an increase in the number of white blood cells, and leukopenia is just the opposite, a decrease in the number of white blood cells. With qualitative disorders, this means that the white blood cell count itself may be normal, but the quality is altered to some extent, and they can't function as well as they should. And these include leukemias and lymphomas, which we will speak about shortly. Okay, now if we look a little bit closer now at the disorders of white blood cell function relating to quantity, again we have leukocytosis and leukopenia. So leukocytosis being the increase in the number of white blood cells, include an issue with granulocytes. Speaking more generally, so granulocytosis, it can involve neutrophils called neutrophilia, which is more common. It can also involve eosinophils called eosinophilia, as well as lymphocytosis involving the lymphocytes. Now on the far right here, you can see the causes of these disorders. So sometimes when there's an increase in the number of white blood cells, it can be because there's some sort of bacterial infection or inflammation present in the body. We can also have more immature white blood cells being released, and this is represented by bands of white blood cells in a blood cell test, where it's evident that there has been shifting to the left. With eosinophilia, the cause is related usually to allergies or parasites. So for example, with allergies, a person that maybe is suffering from eczema due to, let's say, a milk sensitivity or lactose sensitivity or other, they might show increased levels of eosinophils in a blood test compared to that of normal. Lymphocytosis is caused by acute viral infections, in particular the Epstein-Barr virus, which we'll talk about today. And then we have leukopenia, which again is a decrease in lymphocyte count or a decrease in white blood cell count. And this can affect the granulocytes, and that's referred to as granulocytopenia. So that's a little bit more general, affecting the granulocytes. Or it can affect the agranulocytes, and we call that agranulocytosis. So referring, of course, the types of white blood cells. It can specifically affect the neutrophils, and we call that neutropenia, or it can just affect the lymphocytes, and we call that lymphocytopenia. Okay, so reduction in the number of white blood cells in terms of quantity. Now, in terms of the causes of leukopenia, the cause specifically of granulocytopenia and agranulocytosis include chemotherapy, as well as interference with hematopoiesis, and we know hematopoiesis is the formation of new blood cells. Neutropenia can be caused by a prolonged severe infection, which ends up causing a reduction in neutrophil production, which can then actually lead to a decreased survival rate of the affected person because their ability to fight off infections has been reduced substantially. And we've learned so much so far in both normal anatomy and altered physiology the importance of neutrophil function within our body. And then we have a case of immunodeficiencies and drug use and certain viruses that can lead to what's called lymphocytopenia. And when I talk about immunodeficiencies, I'm referring to, for example, HIV. So these can lead to immunodeficiencies like HIV. Certain drugs and certain viruses can lead to a reduction in lymphocyte production. Moving on now to a particular infection called infectious mononucleosis. You might have heard of it as mono. This is best described as being an acute infection of B lymphocytes. Okay, acute infection of B lymphocytes, and we know that B lymphocytes are primarily involved in antibody production. Now, this is a viral infection by the Epstein-Barr virus. Just skipping down here for a moment. And it's transmitted by saliva or by mucosal secretions. A person is usually infected during adolescence or later, and it's also caused by or called rather the kissing disease, and it's more commonly seen when kids go away to university and there's more sharing of saliva and mucosal secretions, even if it's just simply by sharing drinks. But this 35 to 50% risk is saying that 35 to 50% of people that contract the Epstein-Barr virus will end up developing infectious mononucleosis, meaning that, for instance, in children, they might come into contact with the Epstein-Barr virus, but they oftentimes don't develop mono. Clinical manifestations include fever, sore throat. Some of the effects on the lymphatic system include swollen lymph nodes. There can be increased lymphocyte count, as well as an increase in the number of atypical or activated lymphocytes within their body. Now on this slide, we're going to differentiate between leukemias here and lymphomas. Leukemia, as I'm sure you're aware, is a cancer of white blood cells, and usually due to, you could say, excessive accumulation of leukemic cells or atypical white blood cells. Okay, excessive accumulation of leukemic cells or atypical cells. And there are different types, for which include acute versus chronic leukemia, but also myeloblastic and lymphoblastic leukemia. And we'll talk about these terms collectively together and what they mean shortly. With lymphoma, this is cancer of the lymphocytes specifically. And there are two types, Hodgkin's and non-Hodgkin's lymphoma. I'm sure you've heard of both of them, but there is quite a difference between the two, and one has a much better prognosis. With Hodgkin's lymphoma, it's much easier to treat and therefore has a higher survival, but non-Hodgkin's lymphoma is much more difficult to treat. It's because it's far more aggressive, so enabling or reducing survival rate in comparison to Hodgkin's lymphoma. Okay, we'll move on now to the next slide. Okay, let's move back to talking about just leukemia specifically. You can have acute lymphocytic leukemia. You can have acute myelogenous leukemia. You can have chronic lymphocytic leukemia. And you can have chronic myelogenous leukemia. Individuals that have acute leukemia have a higher number of immature or undifferentiated cells at the starting stage. Okay, so if we're looking at matching it up with particular colors here up on the screen. So you can see here that the lymphocytic leukemias are in red and the myelogenous leukemias are in blue. And we're looking at the acute cells, the cells of acute leukemia here, and the cells of chronic leukemia here. So I just already told you that individuals with acute leukemia have a higher number of immature or undifferentiated cells at the starting stage, whereas individuals that have chronic leukemia, they have a higher number of mature cells, and these mature cells do not function normally. Okay, so the predominant cell is mature, and that's where it gets its name cyte from, whereas with the undifferentiated or immature cells, they're still called blast cells. But with chronic leukemia, the cells just don't function normally. In both cases, however, the cells are considered to be, and you should make note of this, both atypical and non-functional. And in terms of acute versus chronic, it relates to the actual stage, the cell stage, okay, which is evident in this image here. And in terms of lymphocytic versus myelogenous, that's dependent on the actual cell type. The last thing I would like you to make note of on this slide is that lymphocytic leukemias, okay, so in red, lymphocytic leukemias are leukemias that occur in populations of B cells, natural killer cells, and T cells. And you can see that if you look closer at this diagram. Whereas myelogenous leukemias, so in blue, are leukemias that occur in populations of macrophages, eosinophils, neutrophils, basophils. So that shows you the difference then between lymphocytic and myelogenous, which is dependent on the cell that's affected, whereas acute versus chronic refers to the stage. In terms of some general features of leukemia, there's uncontrolled proliferation of these malignant leukocytes. Okay, uncontrolled proliferation of malignant leukocytes, which ends up causing, because there's so many of them, it causes overcrowding of bone marrow. And what will happen subsequent to this is there'll be a decreased production of normal hematopoietic cells in terms of the number. And I'm referring to all, not just specific to leukocytes, okay? So decreased production of normal hematopoietic cells because of so much overcrowding within the bone marrow, so the bone marrow can't produce what it's normally used to producing. And what we end up with is a decreased function of normal hepatic hemopoietic cells, which is called pancytopenia. Pancytopenia is, you can consider it to be a deficiency of all three cellular components of the blood, including red blood cells, white blood cells, and platelets. So then people that have leukemia can end up with conditions that you should be familiar with, such as anemia, thrombocytopenia, so a reduction in red blood cells, a reduction in platelets, and of course leukopenia, so reduction in the production of normal, healthy red blood cells, white blood cells, and platelets in terms of their number. So continuing on with leukemia, in particular now looking at the signs and symptoms of leukemia, the abnormal leukemic cells have the ability to infiltrate other tissues, in particular the liver, the spleen, and lymph nodes. So they infiltrate these other tissues and cause enlargement of the liver, enlargement of the spleen, enlargement of the lymph nodes. In acute leukemia, it can infiltrate the bone, as stated here, and this can cause bone pain. In addition, you'll see such features as hyperuricemia, which causes gouty arthritis, anorexia, so weight loss, even loss of taste can occur. And I'd mentioned on the previous slide that it can cause disorders of red blood cells, leading to anemia. And so some of these clinical manifestations might include fatigue, right? Pallor, paleness. And it can also affect the production of antibodies, which can then cause symptoms such as low-grade fever and infection, because we're not producing antibodies, our lymphocytes, that help us fight off infection. So we might be more prone to be infected by pathogens that would otherwise be relatively easy to fight off. I also mentioned with acute leukemia that there was a reduction in the number of platelets called thrombocytopenia. And when this happens, it can lead to bleeding. We will also see potentially thrombocythemia. So you can actually get an increase in the number of platelets sometimes seen as well. And when this happens, it can increase a person's chance of developing a thrombosis or a clot, or somebody can develop a condition called DIC, which we'll talk about shortly. Accumulation of abnormal leukemic cells within the brain can also occur, and this can lead to neurological changes, and it can also lead to cerebral bleeding. With chronic leukemia, Some of the common clinical manifestations include night sweats. But with chronic leukemia, again, this is related to staging, it advances slowly and sometimes insidiously, where it can come on out of nowhere. Okay, let's talk about alterations now in lymphatic function. So we're referring to the lymphatics now. Something called lymphadenopathy occurs when lymph nodes enlarge enough that they become palpable and tender, and you can see that here. This is a bit more generalized lymphadenopathy, and they become not only palpable but visual to the eye, as well as very tender. And this is more generalized. There's other areas that you can see have it as well, but it can also be local. So you can have local lymphadenopathy or general lymphadenopathy. Some of the causes include tumors, so neoplastic disease, immunological or inflammatory conditions can lead to lymphadenopathy, endocrine disorders, as well as lipid storage disease. Now, looking at malignant lymphomas, this includes Hodgkin's lymphoma and non-Hodgkin's lymphoma. And it involves the malignant transformation and proliferation of lymphocytes becoming non-functional. And what ends up happening is crowding occurs, which affects the normal function of cells, right? Affecting function of normal cells. And this can start in one organ and then progress to other areas. The condition is staged from 1 to 4, and this is based on the number of lymph nodes that are involved, and then of course the extent of the spread. Okay, so that's either Hodgkin's or non-Hodgkin's lymphoma. Let's speak for a few minutes now about hemostasis. And if you remember what hemostasis means, it's the tendency towards a relatively stable equilibrium within our blood. And heme referring to blood, stasis is that balance. And there are 3 stages of hemostasis that you need to be aware of. But in order for hemostasis to happen, what we need is a functional bone marrow. Okay, so functional bone marrow in order to produce platelets. We also need a functioning liver to produce clotting factors. And then what we also need from the liver is going to end up being the production of fibrin in order to later contribute to the clot because of these clotting factors. But then we also need substances available to actually dissolve the clot afterwards once we no longer need it. So in terms of the stages of hemostasis, number 1, the platelet plug forms. Number 2, there's formation of the clot, and this is where tissue repair is occurring. And number 3, we need dissolving of the clot that we no longer need. So 1 is platelet plug formation, 2 is the actual formation of the clot where tissue repair begins, and 3 is the dissolving of the clot that we no longer need. Sometimes clotting factors can be impaired, and the 4 main causes on this that are listed on this slide include vitamin K deficiency, liver disease, thrombocytopenia, and hemophilia. Starting with vitamin K deficiency, clotting factors need vitamin K in order to be formed, and the clotting factors are in green here. And so when we're missing clotting factors, it's usually because of some sort of malnutrition or malabsorption of vitamin K. Liver disease, the liver produces clotting factors, as you know. Liver disease can oftentimes be caused by cirrhosis, but can also be caused by any form of hepatic cell failure. Those are examples. And so when we have liver disease, we have a reduction in the synthesis of coagulation factors, and so we have an inability to control blood loss, and we lose the ability to properly clot. Number 3 is thrombocytopenia. So of course, if we have a reduction in the number of platelets, we're not able to form clots the same way. But this can happen in 2 forms. You can either have a reduction in the production of platelets, or platelets are overconsumed. And this will be explained on an upcoming slide. And lastly, hemophilia. It's another cause of impaired hemostasis because people with this inherited condition do not produce enough clotting factors to allow for normal clotting to occur. Our last two slides will cover a condition called DIC, or disseminated intravascular coagulation, which I mentioned on a previous slide. DIC is a complex acquired disorder that is primarily initiated by endothelial damage, meaning that it is usually caused by another condition. And what happens is you have simultaneous clotting and hemorrhaging occurring at the same time. Simultaneous clotting and hemorrhage, and it's because of altered thrombin, fibrin, and fibrinolysis. And the treatment for it is usually to remove the stimulus or whatever other condition is leading to the presentation of DIC. Some clinical signs and symptoms include bleeding from venipuncture sites that you normally shouldn't, bleeding from arterial lines, purpura, petechia, and hematomas. These are just the presentation of, sometimes you'll see little pinprick points on somebody where they're bleeding where they shouldn't be. And symmetric cyanosis of the fingers and toes, so reduction in the amount of oxygen to the distal regions, particularly the fingers and the toes. And again, the treatment is to remove the stimulus, whatever condition's causing the DIC. And on our last slide, just to show you a bit of the pathophysiology of disseminated intravascular coagulation, the stimulus, whatever that condition may be, is going to cause unregulated activation of thrombin. Thrombin, we know, is the factor that causes the formation of fibrin, which is going to create that mesh. And this happens everywhere throughout the body. In other words, the thrombin isn't just remaining localized to an area that's, say, injured. Instead, it's in many different areas. So we end up leading to clot formation in many different areas throughout the body. Now, normally our body has what are called antithrombins present that prevent overclotting. But the problem with DIC is that the thrombin quantity exceeds the antithrombin capability. And now we cannot effectively slow down the clotting process. Multiple clots happen throughout the body because of fibrin formation. So we have multiple clots everywhere. And you can appreciate now the term consumption of platelets, because what we end up having is overuse of our body's clotting factors and platelets. So almost as though we use up all that we have. And so because we use up all that we have, a person can experience accelerated fibrinolysis, which ends up leading to hemorrhage. And we can't stop this hemorrhage like we normally would because we've overconsumed our clotting factors and platelets. And what we end up left with is this widespread ischemia, which can lead to organ hypoperfusion, and then in serious cases can end up leading to infarction. And because of course, not getting oxygen and blood supply to the tissue, which can then lead to multiple organ dysfunction syndrome, or MODS, and that can then subsequently lead to death. And it's multiple organs because we know this is a widespread condition. That's the end of today's lecture. Thank you for listening.